Hopefully, I will provide some, food for thought on this question. So, so we have come a long way since 1987, so 40 years ago. There was a first paper published in neurodevelopmental outcomes in CHD, and it was done by the Boston team by Jay Newberger and collaborators. And they showed for the first time that cognitive performance was reduced in children with TGA. So that was kind of like a really shocking news at that time. And since then, more than 1,000 peer-reviewed articles have been published on the impact of either neurological, cognitive, neuropsychological, and mental health in CHD. So today we know that neurodevelopmental atypicalities, or sometimes disorders, are the most prevalent morbidity in survivors of CHD. So there are currently North American guidelines from the American Heart Association and soon European guidelines that emphasize the need for preventing, for screening, and for remediating these deficits in children, but not only in children, but also across the lifespan, because we are seeing also some of these issues as patients get older. So variation in outcomes can come from different sources. And one of the, I think, most important factors is CHD complexity. So the prevalence of morbidities will vary by CHD complexity. The more severe the CHD, especially the ones who undergo palliation surgery, the greater the neurodevelopmental risk. And this risk is really high for kids with associated genetic syndromes, as you can see in this graph. But the expectations can greatly vary based on several other risk factors that can be cumulative, that can be interactive as well, and we will hear a little bit more about this on the risk factor talk. So where does it all begin? So beyond the genetics of CHD, again, we will have the pleasure to hear more later, there's a growing number of studies that point out the presence of alterations in in utero brain development. So the phenotype of neurological and neurodevelopmental issues in CHD begins really early on, even before the child is born. So this was one of the first papers published in fetal brain development in CHD, and it shows that the altered fetal hemodynamics that is secondary to some types of CHD, inducing decreased blood flow or oxygen delivery to the brain, will result in impaired brain growth, particularly in the third trimester, as you can see in this graph. So what you can see in the y-axis is the total brain volumes and correlated with gestational age, and the comparison between fetuses with CHD and controls. So CHD is in white, controls is in dark black. So these results also extend to other aspects of brain development in fetuses with CHD, not just the volumes, but also the cortical sulcation. So there are some papers that show that the infoldings of the brain during gestation, particularly the third trimester, is delayed. So we talk now about brain dysmaturation in CHD. These studies have usually done in children with critical CHD, mostly cyanotic CHD. So most cohorts include kids with transposition of the great arteries or hypoplastic left heart syndrome. So variations in neurological phenotype in CHD can be seen really early, again, in the prenatal period. So this was an interesting paper published last year from a team from London. And in this study, they sought to really understand the impact of cerebral substrate delivery and some specific CHD diagnosis in the development of the brain and the fetal brain, and particularly in some cortical brain networks. So what they did is they scanned more than 400 fetuses, more than 360 with various types of CHD, and they compared these with a control group, and also between the subgroups of CHD stratified by the level of substrate delivery into the brain. So they had 4 categories for this. So we have normal delivery, which refers to no alterations in fetal hemodynamics at this point. Mildly reduced, which includes some mixing of placental and fetal systemic venous blood. Substrate So moderately reduced, which would refer to complete mixing of placental and fetal systemic venous blood, and severely reduced, which is hypothesized, or at least presumed, to be complete reversal of normal placental streaming. So the results, and this is just part of the, it's just an example of their data on specific network, but the results, as you can see, it's violent plots. They show that the maturation of the specific brain networks, such as the frontotemporal left and right, is vulnerable to the effect of reduced cerebral substrate delivery. And this was after adjusting for gestational age in sex, which could also impact these results. There was a dose-dependent effect for this. So that means that the fetus with the more reduced cerebral substrate, they had the highest impact in the development of these particular networks. So the variations, the substrate delivery can explain some of the variance in these models, but they don't explain everything. So there is also a part linked to the specific type of CHD. And some CHDs are going to be associated with specific development and specific networks. So the reason why this is the case is still poorly understood, but it really raises questions about why, what impact that could have in the long term, and whether we can differentiate different neurological phenotypes in these children. So once the baby is born, 20 years ago, we used to say that one of the critical aspects of neurological injury was microscopic white matter lesions, and they concern more than 40% of newborns before cardiac surgery, and they can go up about 60% after the surgery. And it was mostly focalized on the periventricular lesions of, in the brain in terms of the white matter, sometimes to the level of periventricular leukomalacia. So what this means is that there was this alteration of brain connectivity in the different areas of the brain. And what we know today is that, unfortunately, the rates of preoperative brain injury, and particularly white matter injury, remain relatively constant. But the prevalence of postoperative white matter injury has declined in the last 20 years. So this was a study conducted in the region of California, San Francisco. And over the time span of 20 years, we can see this reduction. I think it was linked by better postoperative care that supported better cerebral perfusion in these newborns. So regardless of microscopic white matter injuries, there is a persistence in white matter alterations in terms of microstructure in CHD, in terms of the white matter. When we look at the different papers from different countries, we can see that there's a systematic, reports of decreased neural markers of brain maturity, such as, for example, fractional anisotropy, which is an indicator of how much development or maturation white matter has at some point. And this is seen in children, in adolescents, and also in adults with CHD. So what are the implications for neurocognitive phenotypes when children start to grow up and go to school and become adolescents and young adults? So what we know today is that the findings in terms of neurodevelopmental deficits depend on the time that you evaluate these children. So we have a very high prevalence of motor delays, motor coordination delays in children, and they start quite early in development. So about, depending on the type of CHD, 30 to 60% will present some type of motor developmental delay. Language disorders are also relatively prevalent, behavioral problems, and something that is called executive functioning which is, the group of functions that allow to pay attention, to concentrate, to remember things. This is quite high in terms of deficits. It's about 50 to 70%. So there are, variations, but the overall prevalence is actually very concerning. So when we look at the early development, we see that we have this abnormal scores quite early. So when we look at children, 8 months old, we can see that about 15 to 20% will have some abnormal scores. That means 2 standard deviations below the mean, which is actually of clinical significance. And if we don't do anything, like we don't intervene or propose any strategies to compensate that, these problems will increase significantly to reach almost 40% at 24 months. And so you can imagine the trajectory later on. If we don't do anything, it would only be worse. I mean, there's a very low probability that these things can compensate or catch up with time, and the wait and see approach is definitely not recommended. So when children are a little older, so around age 3, these are very general results from one of our studies from the EPICAR registry. It's a population-based study conducted in the region of Paris. And what this study showed at this age is that the majority will have a normal global intelligence, so normal IQ, but there are almost 40% that, despite this normal IQ, will have some level of neurodevelopmental impairment. And that could be executive function issues, could be social emotional issues, behavioral control. And so I think the point here is that IQ is definitely not everything in this population. So this is just to, to show you the distribution, the normal distribution of intelligence scores in the general population. So you have a mean of 100, standard deviation of 15, and if you're in this side of the, this one, well then your IQ would be lower and this will be higher. And this is an example of a superimposed curve for the population with CHD. So you would still have a normal IQ within the normal range, but you would have a little bit more cases here in the low range tail of the distribution, and a little bit less here. It doesn't mean that you won't have patients with high IQs, and obviously this is absolutely possible. It's just that the probability it's a little shifted towards the left. So again, IQ is not everything, and particularly in CHD, it's really important to understand that when we talk about outcomes in isolated CHD, we're not talking about intelligence for the most part for many of these kids. We're talking about very specific deficits that impair quality of life, that affect the child's ability to succeed academically, and that poses a problem in society in the long term. But again, it doesn't have to be intelligence overall. So one of these issues is visuospatial skills, and I tend to present this because it's quite visual, as I say. I mean, it's a figure that we ask children to copy and then to remember it and then reproduce it by memory. So it's a neuropsychological test that we have a specific scoring system. And it requires a lot of, visuospatial integration and the integration of many sections of the brain. So this is what we typically see in children, 8-year-old. It's not perfect, again. Pretty sure you're trying to figure out whether you would be able to do it right. It doesn't have to be perfect, obviously, but we can see that the integration of different parts are still there. And maybe you miss a couple things or you just misplace some things, but that's absolutely fine. But this is what we sometimes see in kids with critical CHD. So again, it's just an example. It doesn't mean that all children will have exactly the same pattern, but what we tend to see is that there's a lot of disorganization in the way that they, apprehend visual information. And this is really, I mean, you can imagine the difficulties that they could face, when learning mathematics or geometry or, things like that. So there's a real impact in the child's life. Another thing that we talk a lot about, because rightly so, because of the prevalence of executive function disorders. Oops, sorry. Is this higher order neurocognitive skills that are systematically impaired in many of these children to different extents. It doesn't mean that it has to be severe. It might be mild deficits, but they're still there. So problems with inhibition, that's quite common in the phenotype with CHD, problems with impulsivity, difficulties changing plans, for instance, cognitive flexibility, so switching from one task to the other one, problems with working memory, kids that forget, things at school every single day. So it's really problematic for the teachers, it's problematic for the parents, and obviously at some point it will affect a child's ability to feel that, that they can achieve things and affect their self-esteem as well. So parents report that, but we also see that when we perform the neuropsychological evaluations using standardized tests, and we can objectify some of these things quantitatively. So these are some of the data that we gathered in a study here at Nugget Children's Hospital in a cohort of children with TGA. And we compared this group to a control group, typically developing children. And we can see is that there's this persistent gap between the group with TGA and the control group, despite a normal IQ. Again, I repeat this information very often because it's really important. So there's a neural component to it. So when you see adolescents, for instance, in this case, or children who have executive function issues, what we see in the brain scans or in the, in the brain MRIs, and in this case it's the diffusion tensor imaging, you can see the alterations and the dysmaturation of some of the white matter tracts in the brain. So there is a correlation between what we see behaviorally and what we see biologically. So there is a similar trend, and this is for executive function, but you could also apply that for some other aspects of neurodevelopment. So when you have a group of complex CHD, mostly cyanotic, TGA, TOF, single ventricle in this case, you have a very similar trend of deficits. It can vary, but the curve is really the same, and you have single ventricle patients who tend to perform a little bit worse, but it's still following the same pattern for the other groups. So there is variability also in outcomes even within a single CHD. So take, for example, the transposition of the great arteries. It's quite homogeneous, quite a homogeneous group of patients. But if you stratify these group into, risk factors such as prenatal diagnosis, for instance, or versus postnatal diagnosis, you can see quite different outcomes. So in this particular study, again, here in Necker Hospital, we compared, the kids who were prenatally diagnosed versus postnatally diagnosed. And what we see is that most of the differences actually were coming from the postnatally diagnosed group. So they were performing lower consistently in most of the executive function outcomes, whereas the prenatal group, we have a little bit of impairment here and there, but it was not driving the difference between the groups. So that's something to consider when we talk about variations, even within a single type of CHD thought to be very homogeneous. Another thing that is quite concerning in this group is the risk for autism spectrum disorders and social cognition deficits. So we know today that there's a 4-fold increased risk of autism in children with CHD compared to the general population or reference population over the same time period. But most of the children will not receive a autism diagnosis. Some of them, and most of them actually, will be in between, the lines and not enough severe to be diagnosed with autism, but have some issues with social communication, with repetitive behaviors, and so on. So I think this is the most important issue, that almost half of them will have some of these difficulties without actually being labeled as autism. So we still have a long way to go for this. We just started, I think, understanding these consequences, but I thought it was important to mention because it's becoming a real issue. So I'll just go for this one. Something that I think it's also critical in CHD is considering mental health. So we talk a lot about neurodevelopment, and that's obviously really important, but it cannot exist without considering psychological outcomes and psychiatric outcomes in this population. And the prevalence of mental health issues is extremely high, especially in types of CHD such as HLHS. We have almost 65% of adolescents who at about 14 to 16 years old had been already diagnosed with a psychiatric disorder. So that is, it's a true red flag for the future. And most of these things are anxiety disorders. And so I think the prevention should also target this very important component. So in conclusion, as we have seen in this talk, so there are quite a few variations in neurodevelopmental phenotypes. It will depend on several risk factors, but also on some protective factors. I think we have to consider both sides, right? I mean, we talk a lot, again, about risk, but what about protection? Like, what can we do better, and how can we modify this trajectory? So the take-home message is really that these issues are important. They're very prevalent. They're very frequent. They can tremendously affect quality of life in these kids. But there are ways that we can improve them. And brains are, adaptive and malleable, and some things respond very well to treatment. So I think we're in a very decisive period to make things change for these kids. Thank you.